On behalf of the MS Society of Canada, I welcome you to today's webinar. My name is Rochelle Phoenix, and I'm the Senior Community Resource Coordinator for the Northern Saskatchewan, and I work out of the Saskatoon MS office as part of the Programs and Services team. I will be your moderator for today's webinar. We are pleased to have Dr. Ilia Poliakov, Director of the MS Clinic in Saskatoon and MS Neurologist Specialist, as our presenter. He'll be talking about medications used to manage multiple sclerosis. Before we start, I have a few items to share. Everyone will be muted automatically for the duration of the webinar to ensure the best sound quality. If you do have questions, just please type it in the chat box and we will try to get to as many questions as possible in the allotted time following his presentation. You will not see an image of the doctor, but you will see his slides while he talks. Okay, well, we'll hand it over to Dr. Poliakov.
Hi, everyone. This is Dr. Ilia Poliakov. I'm the clinic director at the Saskatoon MS Clinic. I've likely met a number of the people listening along today. It's my pleasure today to present on MS, but this time with more of a focus on the treatment of multiple sclerosis. I'm just going to share my screen here. So you should all be able to see my slides right now. Please just type in the chat box or let the organizers know if you can't. So I'll get started here and I'll try to present for roughly 45 minutes and we'll leave about 15 minutes at the end for questions. Okay, so as a quick outline for our talk, we're going to very briefly go over MS, what it is and what it isn't. We're going to talk about the non-pharmaceutical options for MS management, those that are proven and those that are unproven. We'll talk about what our goal is when we're treating multiple sclerosis to kind of set up the framework for the overview of the various MS therapies that are approved in Canada right now. We'll talk a little bit about when to start therapy, kind of what our ideal timing is. We'll talk about what it's like to be on therapy and what to consider while on therapy. We'll talk about when to stop MS therapy. I'll have a brief word on progressive multiple sclerosis and then a few brief words on what's on the horizon right now. So in terms of what MS is, we generally consider multiple sclerosis as a chronic, which means it's a long-lasting disease. Immune-mediated, we think it's autoimmune, that the immune system gets confused and starts attacking the body. Inflammatory, and when the inflammation is in the brain or spinal cord, it usually results in demyelination, which is stripping away of the fatty substance that connects or that covers the processes that connect brain cells together. That fatty substance is called myelin. And MS affects only the central nervous system, which means it only affects the brain and spinal cord, technically the optic nerves as well, as they're an extension of the brain. It doesn't really affect anything else. So again, a chronic immune-mediated inflammatory disorder of the central nervous system. However, while it is primarily or initially an inflammatory condition, over time, MS also develops, in some patients, develops a progressive component, which is more of a degenerative condition. So this makes MS different from a lot of diseases as there's two phases to deal with. The inflammatory component of multiple sclerosis we usually refer to as disease activity. So when I use the term activity, I'm usually using it synonymously with inflammation. Activity can be in two forms. One are clinical relapses. This is very commonly seen in relapsing remitting MS. So these are new symptoms that might remit. Sometimes they don't fully go away. The other is new MRI lesions. So we have the advantage in MS that we can see the disease activity under the hood, so to speak. And so we can see silent inflammation, which causes lesions on the MRI, but no symptoms. In general, for every relapse, there'll be about 10 new lesions that form on an MRI. Patients who have primary or mostly inflammatory activity, we call that relapsing remitting multiple sclerosis. Now, the other side of MS is the progressive disease. when I talk about progression, what I'm referring to is a gradual decline of function, be it physical or cognitive function, which is independent of activity. So that means that decline is independent of having relapses, and it's independent of developing new MRI lesions. When we see disease that's mostly typified by progression, we call that primary progressive MS if there's no history of relapses beforehand, or we call it secondary progressive MS if there is a history of relapses beforehand. For the most part, I think most MS specialists would agree that primary progressive and secondary progressive MS are the same disease. It just one happened to have a relapse before. The other, with primary progressive MS, there probably were silent relapses before. That is, there were new MRI lesions that did not cause symptoms before the progression took hold. Now, while I did divide these two out, I think it's important to remember, especially for the context of this talk, for the purposes of this talk, that MS activity, so that is new inflammation, and MS progression can occur simultaneously in the same patient. In fact, in most MS patients, there's probably some element of progression and some element of inflammatory disease. However, we see more active disease in patients who are younger, who are earlier in their MS disease course, and who have lower disability levels. This is not a hard and fast rule, but just on average. Alternatively, in patients who are older, who have a longer disease duration and who have higher disability levels, we tend to see more progressive disease. That is, this gradual worsening over time, independent of relapses. And as I said, most patients have some combination of the two. So I kind of like to imagine MS being on two spectrums. So on one hand, we have disease activity, and it can be less active and more active. So how much inflammatory disease there is, and then how much progression there is. So how much worsening there is over time, independent of that activity. So you can think of it in these two dimensions, and patients can fall in any number, in any spot on this grid. So here would be an example of a patient who doesn't have much in the way of active disease and does not have much in the way of progressive disease. This is sometimes referred to as benign MS or mild multiple sclerosis. A bit of a controversial term, but MS is such a diverse disease, and there are some people who are doing very, very well on all fronts. And fortunately, as the decades go by, new MS cases are more and more likely to do well. Here's a patient who has a lot of disease activity, so a lot of inflammation, and less progressive disease. Here would be a patient who has a lot of progressive disease, but still has some inflammation, still has some disease activity. And this would be an example of a patient who has very little in the way of inflammatory activity, but is progressing, so might be worsening from year to year. Depending on where patients fall in these spectrums, it kind of guides our treatment options. So as a very, I guess, simplistic way of looking at this, disease activity, that is that inflammation in the brain or spinal cord, causes sclerosis, which is another term for scar tissue. These areas of sclerosis can themselves directly impair function. So for example, if somebody had optic neuritis and then developed some sclerosis in that optic nerve, their vision might never be the same in that eye. Fortunately, with optic neuritis, it often recovers very well. When we see disability secondary to a relapse or secondary to a new MRI lesion, we usually call that a relapse-related disability. However, what this sclerosis can do is it sets up a cascade, a degenerative cascade that over time causes wearing away and atrophy of these areas of the brain affected, and that leads to progressive MS. It doesn't happen to everyone, and it happens at different rates in different people, but that's the general idea. So hopefully by preventing inflammation, we prevent the formation of sclerosis, and then we prevent long-term progression of disease later on, 15, 20 years down the road. So with that kind of overview in mind, let's switch gears and talk about treatment in MS. So first, I'm going to start with the non-pharmaceutical therapies. Anybody who's been in clinic with me has probably heard my spiel about the healthy lifestyle factors that influence multiple sclerosis. These will influence both relapsing remitting MS and progressive MS, so active disease and progressive disease, and influencing them for the better. So it's very important to stay physically active And generally, the studies show that any activity is good activity. There's not like the right type of exercise for MS. Similarly, mental activity is important. Again, any sort of mental activity, reading books, watching movies, talking to family and friends is good. But here in general, novel activities, so trying new things seems to be better at protecting brain function. We do think that taking vitamin D at 4,000 units a day is beneficial. The science behind this is, to be honest, is a little bit lackluster at this time, although the evidence base is building. However, it is almost certainly safe. So that dose of vitamin D for any adult in Saskatchewan is safe, and if it has a benefit, which it may well, then that's great. If it doesn't, there's really no loss. Smoking is detrimental to multiple sclerosis. There's a lot of other ill effects for smoking, so it's a good idea not to smoke. Having a healthy diet is important. There is some evidence in mice with multiple sclerosis, and that's a very poor model for humans, but in mice with MS, high fat, high salt diets might worsen their MS. Luckily, it's quite easy for me as a doctor to not recommend high fat, high salt diets in humans for a number of other reasons. But a general common sense healthy diet with lots of fruits and veggies and low in fat, low in salt, and low in refined sugar is probably a good idea. We know that patients with MS are more likely to develop comorbidities, so that is other conditions like high blood pressure or heart disease, and it's important to treat those because they can negatively affect the brain. I see I have a little typo there, there should be an R. Other things that have been studied with some evidence include mindfulness and stress reduction, having a good amount of social capital, so having lots of social connections, be it family, friends, or support groups. And for those patients who can continue working, emphasis on can continue working, but if you can continue working and do so, tend to do better with MS. So this is, I really view this slide as kind of like half the battle in MS treatment. It's very important. And as I said, this is effective in both active and progressive MS. I want to emphasize that those healthy lifestyle factors are not a cure for MS, but they can slow down that accumulation of disability. And I think it's important because for all patients with MS, this gives back some control over the disease. There are things that you can do every day that can make your MS better. Now, beyond vitamin D, there's been a number of other vitamins and supplements that have been touted as a treatment for multiple sclerosis. At this point, there's very little evidence for any of these. And as I said, even for vitamin D, the evidence is a bit lackluster. Just an example of a few of the things that have been studied with smaller trials include omega-369 fatty acids, high dose of various B vitamins, including biotin, which we'll talk about later, and vitamin B12, melatonin, alpha lipoic acid, and various antioxidants. Now, these are all probably safe to take. Having said that, it's unclear if they have any benefit in multiple sclerosis. So I'm not sure if I would recommend any of them at this time. The omega-369 fatty acid story is interesting because in a lot of Scandinavian coastal communities, it was found that the patients on the or people on the coast had much lower rates of MS than people inland. And the initial theory was that was because of the omega-369 fatty acids that are present in fish, and the people on the coast had a diet that was very heavy in fish. However, fish also has a lot of vitamin D, so that was a big confounder. There's been a number of studies on omega-369 fatty acids since, and they always kind of go back and forth. Some show a bit of a benefit, some don't show any benefit. So my conclusion of that is if there is a benefit, it's likely mild. There have been more and more studies showing that there's not really much benefit to anyone in having a multivitamin, which I know is a bit of a shocking conclusion, but a number of large meta-reviews have recently been done and kind of shown that if somebody has a generally healthy diet, they don't gain much by being on a multivitamin. And if somebody doesn't have a healthy diet, they're much better off having a healthy diet than going on a multivitamin. So for the most part, I just recommend a balanced, healthy diet with lots of fruits and veggies. So this brings me to the next bit about supplements. As I know there are a number out there that claim to enhance brain function. These are sometimes called nootropics. Um, uh, in short, there's really no evidence for any of these. Um, when people with MS or people without MS are given something that says and told that they're going to perform better on a cognitive test, they usually perform better on that test, even if they were just given a placebo. And all these nootropics out there really have no proper trials against placebo. So I generally don't recommend anything that has the claim that it enhances brain function. It's a bit of an empty claim. And speaking about diets, I also realize there's seemingly 1,000,001 diets out there that claim to cure or manage MS. But the fact is, there's no scientific evidence for any of them, with the exception of what's called a Mediterranean diet. Nobody quite knows how to define this, but it tends to be heavy in fish and nuts and olive oil and things like this. So these kind of unsaturated fats. But a Mediterranean diet had a slight benefit in MS. But again, nobody can quite define exactly what it should be. Other diets like the Swank protocol and the Walls diet, etc., there's really no evidence that they're beneficial in MS, although again, they're likely safe. I would caution about any diet that's overly restrictive, as there is a chance that as you start to cut away enough things, that you'll cut away a vital nutrient or a vital vitamin or mineral. And having said that, if you're eating lots of fruits and veggies, you're probably good. So again, try not to be too restrictive. I realize that a lot of patients and a lot of people in general have been cutting out cow's milk or dairy and cutting out gluten. Those are probably safe to cut out. I don't think they negatively impact multiple sclerosis, but it is probably safe to cut out dairy and gluten and not really have any ill effects. So another, I guess, sort of medication that's been making the rounds is low-dose naltrexone. So naltrexone is used as a reversal agent for narcotics. So there are like naltrexone kits, for example, out there for when patients overdose or for when people overdose, and they can the effects of the narcotic on breathing function can be reversed with high-dose naltrexone. This is a much, much lower dose than that. There was an early study in California with Dr. Cree looking at the effect of low-dose naltrexone on MS. And it did find in this very small study, from which conclusions can't really be drawn, but in this small study, there was some subjective improvement, and people reported a better quality of life in some measures. However, since then, there hasn't really been any further research or any proper trials showing a benefit of low-dose naltrexone. A more recent study out of Norway, where there's been a high uptake of low-dose naltrexone use, showed that it did not reduce the use of other symptomatic medications for multiple sclerosis. So again, it's unclear if there's really an objective benefit. For the most part, I do not recommend low-dose naltrexone, and I think more research is needed. The liberation therapy, or CCSVI, has a very interesting history in multiple sclerosis. So for those not in the know, the idea here was that MS was primarily a vascular disorder, a disorder of blood flow. This was championed by Dr. Zamboni in Italy. As an aside, his wife had MS and he's a vascular surgeon. I don't think he was malicious with his intent. I think he really wanted to help his wife, but it is a bit of a red flag when a vascular surgeon finds a vascular cause and cure for multiple sclerosis. The idea was that the jugular vein, which helps drain blood from the brain, could be stented open or ballooned open and allow better blood flow out of the brain, and then this would help with multiple sclerosis. An early study, again, showed purely subjective improvements, but this really took off, especially in the prairies. The rates of this procedure in MS patients in Alberta and Saskatchewan was very, very high. And it took about a decade until the sham trials were done. So this procedure was compared against a sham trial where a patient would have an incision on their neck, and then while they were under anesthesia, and then it would be stitched up, but there was no actual intervention to the jugular vein. And in those patients who had a sham trial and who had the real procedure, there was no difference in outcomes. This was then replicated by a similar sham trial by Dr. Zamboni himself. So I think this is a procedure now for which there's really no evidence. There's no justification in getting it done anymore. There's a lot of interest in stem cell infusions. The idea here is to take someone's stem cells, amplify them, and then inject them back in the body so they can go to areas of damage and heal the damage. It's a very nice idea in theory, but unfortunately, it just doesn't work right now. If I inject stem cells into someone's veins, even assuming I can collect the stem cells and properly amplify them, which is a big if, but if I can do that and I inject them into someone's veins, they're going to get stuck in the lungs. And even if they can get just the way the blood flow is hooked up in the body, venous blood will eventually end up in the lungs to get oxygen, and all the stem cells will get stuck there. But even if they can make their way out of the lungs, they can't actually cross into the brain because the brain is protected by something called the blood-brain barrier. So I would be very skeptical of any stem cell clinics right now, although there is some proper research going on, which we'll talk about in a little bit. And the last thing I wanted to mention, because this was actually a question last time I gave a talk for the MS Society, somebody asked me about these neuromodulation devices and whether there was any evidence in multiple sclerosis. And at the time, I didn't think so, but there was a small trial done for this PONS device in Montreal. It was a very small pilot trial. Again, we cannot draw conclusions from those because they often end up being negative in larger trials, but this small trial did show some benefit in physical and cognitive functioning in MS, but it really needs replication. This PONS device is a little bit interesting. The way it works is it's actually an electrical stimulator that goes on the tongue. And then the idea is that that electrical stimulation is going to travel up two nerves, the hypoglossal nerve, which controls your tongue movement, and the trigeminal nerve, which controls your tongue sensation. That increased electrical stimulation will travel up those nerves and then have beneficial effects in brain function. Again, there's a lot of, let's say that's a bit of a hand wavy explanation. And so far, the evidence has not been striking. It was recently approved for mild traumatic brain injury in Canada, but based on very shaky evidence. Ultimately, I don't think it's going to have much of a role in multiple sclerosis or in the treatment of walking dysfunction. But I guess time will tell. So now moving on to our approved MS therapies, I want to start by just talking about what our goals of treatment are. So in general, we are treating active multiple sclerosis. So that is that inflammatory phase of multiple sclerosis that causes new MRI lesions to pop up and causes relapses. It's very important to remember that MS treatment is preventative. We are trying to prevent relapses. We're trying to prevent new MRI lesions. By doing so, we prevent short-term disability. And by doing that, we're hopefully preventing long-term disability. But MS treatment of any stripe does not reverse disability. There are actually a few exceptions to this with some of the newer medications showing some reversal of disability, although part of that might be people just recovering from relapses and then looking like there was a reversal of disability when it was all just relapse related. But some of the newer medications might actually have more of a benefit in this regard, but for now, we certainly cannot promise any reversal of disability. Our MS therapies do not remove those MRI lesions that form due to multiple sclerosis, and they do not stop progressive MS, although in some cases, as we'll get to later, they might slow down the rate of progression. So we really want to treat as early as possible. The idea, because it's a preventative therapy, so we want to prevent as much MS activity as possible. As I said, that MS activity can lead to sclerosis, scar tissue in the brain, which can itself cause disability and also trigger a degenerative cascade that causes more disability later on. So we really want to treat as early as possible. In general, the benefits of all our MS therapies will decline as people get older, as MS patients have MS for a longer duration, and the more progressive disease somebody has. I really like this little graph from the MS Trust. So the idea here is that the earlier we treat, if we treat right away, then we have much more an effect on long-term disability. we wait to treat, then there's already been some accumulation of disability. So even if we're preventing future disability, we can't do anything that's already anything about what's already happened. And without treatment, people tend to accumulate the most disability over time. As I mentioned before, though, MS is a very diverse disease, and there are people out there who've had MS for 60 years and never been on treatment and are doing great. There are people out there who have been treated from right from year one and are not doing that well. However, on average, the earlier we can treat, the better people do on average. There's more and more research showing that by having patients involved in the decision-making process, there's better compliance with therapy and better acceptance of therapy. So I'm a big believer of that. I think it's really important that, first off, patients get educated and informed about their treatment options, and then be involved with the decision-making process after that. The goal here is to find a treatment that's effective at stopping MS activity, that's safe, so that fits with the risk profile of the patient, that fits with the lifestyle of the patient, that is affordable, although in Canada, that's generally not too much of a concern if somebody's approved for MS therapy through an MS drugs program. And medication has to be tolerated. As a physician, I can talk some about effectiveness of medications, and I can, I guess, mention expected tolerability profiles. But whether somebody approves of the safety of a medication, whether it fits with their lifestyle or whether or not they find it tolerable, that's really completely up to the patient. So why it's so important for patients to be involved in the decision-making process. As I mentioned before, MS is a very diverse disease. So what works for one person might not work for another. And in general, our treatments should be based on scientific evidence. So for the most part, I will wait for a phase 3, so that's a large clinical trial, before making any drastic changes to the way that I manage multiple sclerosis. So with that in mind, let's talk about the actual therapies and what they are. So there's 12 approved therapies in Canada. There'll probably soon be 13 or even more. And when we look at the different types of these therapies, like different dosages or different ways to give these therapies, there's at least 20 formulations. In 1993, there were no therapies approved. 1996 was when the first therapy was approved in Canada. It was approved a little bit earlier in the United States. All of our disease-modifying therapies have been shown to decrease the relapse rate in MS by up to almost 70%. The MRI lesion burden, so that is the formation of new MRI lesions, in some cases by more than 95%. And they all, or most of them, have been shown to decrease short-term disability as well. Long-term data, which we get mostly from the various MS databases that we have around the world, and also extension trials for the medications we'll discuss soon, does show that over time there's an even more dramatic reduction in the relapse rate, sometimes going down to 1 in every 10 years, having relapse 1 in every 10 years. And most long-term data is showing that there's a benefit in terms of long-term disability, that there's less long-term disability as a consequence of treating. There's a lot of ways to think about our MS medications. One of them is to divide these into immunomodulators and immunosuppressives. Immunomodulators, the idea there is that you're just shifting the immune system into being in a less inflammatory state. In general, these medications are less effective on average, but they tend to be very safe. Immunosuppressive medications actually suppress part of the immune system. Generally, it affects what we call the adaptive immune system. So the innate immune system is the automatic response of the body to any infection. Most of your immune function is from your innate immune system. It just senses something is wrong, and immune cells go there to fix it. The adaptive immune system is a more fine-tuned response of the immune system against a particular bug. So you might get, well, this is actually how vaccines work, is that the vaccine shows part of a virus or bacteria to the immune system, and then it adapts a response against that virus or bacteria so it can rapidly attack it if it sees it again. Thinking with multiple sclerosis is that some part of the adaptive immune system has become confused and is recognizing the brain or spinal cord as a target. So this is why most immunosuppressives focus on the adaptive immune system, generally a type of cell called the lymphocyte. Overall, these therapies are considered more effective, but they also have more potential adverse events. Any immunosuppressive can theoretically increase infection rate, although luckily the infection rates from any of the MS therapies tend to be very low. Our immune systems fight off cancer, and by some accounts, there's 7 subclinical cancers that our immune system fights off in a lifetime. And if the immune system is affected, there's theoretically an increase in cancer risk. And finally, we need a proper adaptive immune system to be able to form a vaccine memory. So if the immune system is affected, vaccine memory or vaccine uptake might be lowered. And again, that really varies from medication to medication. So when we look at our MS medications, the immunomodulators are really mostly the injectable medications. So this is Copaxone and the interferons. Minocycline is a type of antibiotic that has been approved not so much by Health Canada, but has some research in treating very, very early multiple sclerosis. And I know that another trial will be ongoing for that soon, but we don't use it too much. The immunosuppressive medications are listed there. This includes all the oral medications and all the infusion, all the IV infusion. The oral medications are Aubagio, Tecfidera, Gilenya, and Mavenclad, with the infusion medications being Ocrevus, Tysabri, and Lemtrada. And we'll talk about that division here in a little bit. Another way to think about these therapies is to divide them into first and second line. We generally think of first line medications being safer but less effective, with the second line medications being more effective on average, but probably having more potential risks. For the most part in Canada and other central payer systems, the insurance companies and governments require starting with a first line therapy. There's a few ways around this, but generally that's the rule. Currently, our first line therapies include the injectable medications like Copaxone and the interferons, the oral medication Aubagio, the oral medication Tecfidera, and very recently, about 2 months ago, Ocrevus, which is an IV infusion medication, was approved as a first line by Saskatchewan, as well as every other province in Canada, with the exception of BC. The second line medications include the oral medication Gilenya, the oral medication Mavenclad, and the IV infusions Tysabri and Lemtrada. Now, there is also some third line medications. These are very rarely used. This, again, this is for people who have active MS and who have failed the second line. These are pretty heavy chemotherapy drugs, mitoxantrone and cyclophosphamide. And then what many people have probably read about are stem cell transplants. The idea here is to use chemotherapy to obliterate the immune system, take it down to 0, and then give the patient back their own stem cells, which are going to go into the bone marrow and create a new immune system. So this is a hard reboot of the immune system. It is effective for active MS, not progressive MS, but it has a lot of logistical difficulties in setting it up and a lot of potential risks and side effects, including severe infection while you're immunocompromised, infertility after the procedure, and the potential to cause maybe some very early progression of the disease because of the major stress of the procedure. But there's more and more research being done on stem cell transplants. We do have a protocol in Saskatchewan for patients who have failed a second-line therapy and have a low enough disability level and still have active disease. But that's that's a rare case to see. So I've kind of referred to some of these medications as injectable, oral, or infusion. So the injectable medications are given once daily to once every, sorry, that should be 2 weeks, not 3 weeks. The oral medications are generally taken once every other day to twice a day, depending on the medication. And the infusion medications are given between once a year to once a month. So the injection medications are listed here. This is Copaxone and the interferon medications. Glatex is the generic version of Copaxone, which most people on Copaxone have had to switch to Glatex because it's slightly cheaper. The oral medications, Aubagio, Tecfidera, and Gilenya. Tecfidera is the one that's taken twice a day. Mavenclad is an oral medication taken every other day, but not taken for the full year. Infusion medications include Tysabri, which is given once a month, Ocrevus once every 6 months, as well as Rituxan, which is also called rituximab, which is a very similar to Ocrevus and has been used to treat MS in Sweden for a long time. Lemtrada, and as I said, mitoxantrone and cyclophosphamide are third-line medications, but they are IV infusions. We rarely use them though. Another way to divide these is what we consider immune reconstitution therapies versus maintenance therapies. So immune reconstitution therapies, sometimes called induction therapies, will permanently alter the immune system or alter it for a very long term, hopefully in such a way as that when the immune system kind of rebuilds itself, it no longer recognizes the brain or spinal cord as targets. Some of these changes may be irreversible. Some might not be reversible for a very long time. And then they might compound on with any other treatments that are used later on. Maintenance therapies, on the other hand, require continuous treatments to suppress or modulate the immune system. So we only have a few reconstitution therapies, Lemtrada, which is an IV infusion, and Mavenclad, which is an oral medication. Technically, these third-line therapies, the mitoxantrone and cyclophosphamide, which are chemotherapy drugs, and the stem cell transplant are all immune reconstitution. They will markedly affect the immune system so that it has to rebuild itself. The maintenance medications, which just suppress or modulate the immune system, are all the other medications listed here. And finally, we can divide the therapies into effective or highly effective therapies. This is kind of based on opinion. Different people have different ways that they divide the therapies as such. We have very little head-to-head data that is comparing one medication versus another in a proper trial. The little bit of data we do have shows that Rebif is probably a little bit better than Avonex. These are two types of interferons. The oral medication Gilenya is probably better than the injectable Avonex. And both Lemtrada and Ocrevus were compared against the Rebif, and on average were shown to be more effective. However, a medication that's effective or classified as low effective might be very effective in a certain person. So if a medication is working for you, it's probably a good idea to stay on it and not necessarily switch to a medication that is just branded as more effective or highly effective. So the highly effective therapies in general are considered all the IV infusion medications and the oral induction therapy, Mavenclad. The third-line medications are all considered highly effective, but again, they also have high risk. The oral medications, Tecfidera and Gilenya, I consider kind of in the middle of the road as being, let's say, moderately effective. Mavenclad might also end up being a moderately effective option. I think we need more long-term data on it. It's unclear if it will be moderately or highly effective. But again, this is another way to divide up these therapies. Now, effectiveness is just half of the story. We also need to talk about safety and side effects. The side effect profile for every medication is different, and this is why regular monitoring with lab work or MRIs and clinical visits is so vital because we're looking for different things with every medication. The vast majority of the medications are very well tolerated. Some, though, do have higher side effects rates. I would say that Tecfidera is probably the least tolerated medication, but still easily 90% of people tolerate it very well, which leaves about 10, maybe in some cases 15 or even 20% who can't tolerate it that well. We have a lot of options for treating MS now. So if a medication is not effective enough at controlling disease or is not tolerated, we can probably switch to something. Now, actually being on therapy, what do we follow in the MS clinic for patients on therapy? Well, we're following whether or not people are having relapses. We're following their functional status, like what can they do at home, what can they do at work. We're doing a test called the Multiple Sclerosis Functional Composite, which is a test for walking speed, hand dexterity, and cognitive function. We are following MRIs for the formation of new lesions. There is a lot of interest in looking at brain atrophy, so the shrinkage of the brain on MRI. Unfortunately, that's not really available outside of a research setting. And of course, we're doing a clinical exam and looking for any objective changes on our neurological exam. For the individual medications in the clinic, we're following the lab work. For some of the medications, they actually don't need any monitoring lab work, although that's rare. The other medications might need monitoring lab work up to once a month, but we review all that as it comes into the clinic. We're monitoring for side effects. We're monitoring for adverse events, so like the formation of a serious infection while on medication. And we are looking at medication compliance. This last point is really important. Compliance is vital. If somebody's non-compliant and then they have a relapse, and we don't know that they're non-compliant, we might choose to escalate a therapy, thinking that the medication failed when it didn't. And sometimes escalating therapy is, leading to a potentially more dangerous option. So I think compliance is really important. And if compliance is an issue, please let us or please let your doctor know. It is important to report any adverse events. You can call the MS clinic if you're following with us. But also all the MS medications have a patient support program with a nurse assigned to it that can be contacted as well. There's a lot of potential adverse events with these medications. Luckily, they're all quite rare. But a few things of interest. For those patients on Lemtrada, about 30% will get thyroid dysfunction, which is generally easy to treat with thyroid supplementation. About 2% will get platelet dysfunction, so they'll have increased bleeding risk. Again, we can actually treat that with steroids. And kidney dysfunction is very rare at about 0.2%, but if we catch it early, again, we can treat it with steroids. Ocrevus, which is an IV infusion medication, might increase the risk of breast cancer. That's not really clear, but generally we recommend mammograms after the age of 40 or 45, screening mammograms. The medication Tysabri is associated with progressive multifocal leukoencephalopathy, which is a viral infection of the brain, secondary to a virus called the JC virus that most of us have kicking around in our blood, which does nothing unless there's immunosuppression due to Tysabri, then it can affect the brain. We almost always see this after 2 years of treatment. So it's generally quite safe to treat for less than 2 years or for 2 years or less with Tysabri. The oral medication Mavenclad is associated with zoster if the lymphocyte counts go low. So we will not retreat with this medication until the lymphocyte counts are back to normal. Tecfidera can cause GI upset, and if it lasts more than about a month, then it probably won't go away, and it's reasonable to try and switch medication. The oral medication Gilenya is associated with swelling at the back of the eye. This is why it's very important to have an eye appointment about 4 months after starting it. If it doesn't happen within 4 months, it probably won't happen. Aubagio can cause liver dysfunction, and the injectable medications can cause injection reactions, and with the interferons, can cause flu-like side effects, which can be very hard to tolerate for some people. So we follow, as I said, medication effectiveness in the clinic. We have some protocols by which we might choose to escalate therapy based on the disease activity and the MRI. There are some times when we cannot use a medication. So if a certain white blood cell count called the lymphocyte is low, then medications such as Tecfidera and Mavenclad generally cannot be used. And we're quite cautious with the others because they might further lower the lymphocyte count. In Europe, if somebody had been on Lemtrada, they're not allowed to use Tysabri later on. That's not the case in Canada, but we'd be cautious. If there's any active infection, we're almost certainly not going to start an immunosuppressive medication. It's also important to remember that some medications have a rebound effect. This is especially true with Tysabri, that after stopping it, there's a chance that disease activity comes back at a higher level than it was at before. This is being more and more recognized with Gilenya, so switching from these cold turkey inactive disease is not recommended, and they should generally be switched, or stopping these cold turkey is not recommended. They should generally be switched to another medication. As I said, some of these therapies have long-lasting effects on the immune system. So we don't know what happens when we go from one therapy to another, whether or not those effects accumulate. There's actually relatively limited experience in sequencing some of these highly effective immunosuppressive therapies, but we are learning more and more as time goes on. So far, it's looking to be safe. And finally, as I said, for patients who fail highly effective therapies, stem cell transplant is an option, although it's quite rare to see patients get to that level, thankfully. I do want to talk a little bit about stopping therapy. So there's a number of reasons why we might choose to stop MS therapy. The first is, as I said, we are treating active disease. So if MS becomes mostly progressive, then there's not really much benefit to disease therapy because there's no new MRI lesions or no relapses to prevent. So at that point, we can generally stop MS therapy. If MS is stable for long enough, so if there's been no activity for 10 years on treatments, we could consider switching. But generally, the guidelines I use is if someone is over 55 and they've had no activity for 5 years, or they're over 60 and had no activity for 2 years, then it's lots of research is now showing that it's generally safe to stop therapy. We like to stop therapies during pregnancy if we can, although we can certainly, in more active disease, consider continuing the injection medications, such as the interferons. The injection medications are very big molecules, so it's quite unlikely that they'll pass into the placenta, so they're almost certainly safe. Most of the other medications should be stopped. Tysabri is it's an IV infusion. It's generally considered safe in pregnancy, and there are rare times where I will continue using it through pregnancy. This is mostly when I think that a relapse will cause significant dysfunction and make it very hard to parent to actually, the pregnancy, MS doesn't really affect pregnancy, but if somebody loses function of the right arm, it becomes very hard to hold or feed their baby. So there are times in very active disease where we'll treat with Tysabri through pregnancy. The induction therapies, those that change the immune system, are generally not used long-term. They're used for a year or two. So we can often use this medication and then stop it and then allow for family planning 4 or 6 months later. So they do have that advantage. A few words on progressive MS. So progressive MS can still have activity superimposed upon it. So it can still have relapses. They can still have new MRI lesions. And if we see that, then we might choose to treat progressive MS. With primary progressive MS, Ocrevus is a treatment option, although it's currently limited to those who have active progressive MS and who have had MS for less than 15 years. Rituximab is technically approved in Saskatchewan for treatment of primary and secondary progressive MS with activity in those under 51. There is another medication called siponimod, which was just recently FDA approved, which for secondary progressive MS. And interestingly, Mavenclad does have approval for use in secondary progressive MS in the US, not in Canada. However, if there's progressive disease and there's no associated disease activity, there's likely little benefit from treatments, and we generally don't recommend treatment because the harms of all the medications are still there. So if there's no benefit, there's still all the harms. So again, we're treating active disease. And then I just want to finish up with a few of the things that are on the horizon. I just want to caveat first that I don't recommend any treatment until it's concluded a phase 3 trial. A phase 3 trial is generally a randomized double-blind trial, meaning that the doctors don't choose what therapy a patient goes on. It's randomized, and nobody knows who's on what therapy, neither the doctor nor the patient. That's the best way to determine if something is truly effective. And a phase 3 versus a phase 2 trial is just bigger. And we tend to, just through the law of averages, we tend to see more of a real effect with larger trials. There's a lot of things that have looked really good in small trials, even sometimes small randomized trials, which ultimately did not work out. Very recently, there was this MS SMART trial, which was a trial of 3. It actually had 4 arms, 3 arms, each one of these medications, amiloride, which is a diuretic, which is a water pill, riluzole, which is a medication that's used in ALS treatment, and fluoxetine, which is an antidepressant. And then the last arm of the trial was a placebo. There was and this was based on good early research. But when they did the bigger trial, there was no benefit of any one of these medications. Just an example of how things can look promising but ultimately fail. But with that aside, so siponimod, I do suspect will be approved for secondary progressive MS in Canada. I don't know what treatment restrictions there will be on this medication, like whether or not there will be a certain age restriction or a certain disability restriction. There likely will be some restrictions, but we won't know until Health Canada makes their final decision. I suspect it'll be by the end of the year. There are a number of other immunosuppressive medications which are completing or soon to start phase 3 trials. These ones ending in mod are very similar to siponimod, which is similar to fingolimod. So they're not too different from what's already out there. Ofatumumab is a bit of a mouthful. That's actually quite similar to Ocrevus. It has the same mechanism of action, but it's given as a subcutaneous injection as opposed to an IV infusion. It's given every month. Masitinib and evobrutinib are a class of medications called tyrosine kinase inhibitors. Tyrosine kinases are activated in various immune functions. So by modulating those kinases, we might be able to suppress the immune system in such a way as to benefit MS. There's also a number of trials not looking at immune suppression, but rather looking at recovery of brain tissue or remyelination. I don't think any of this is ready for prime time right now, but there is renewed interest in high-dose biotin, vitamin B7. An earlier trial showed some benefit in progressive MS. This really has to be replicated. A lot of people have since started using high-dose biotin, and there have been some adverse events. It interferes with lab work, so it can mask lab abnormalities, such as the enzyme that's released during a heart attack. It masks that. And there was a case of somebody dying because the heart attack was missed. It also seems to cause increased disease activity in some cases. So the FDA right now is actually not recommending using biotin until the replication study is done. Simvastatin is an anti-cholesterol drug, which might have a benefit. A larger trial is ongoing. Clemistine is an old school antihistamine drug, which might have a benefit. Again, another trial is ongoing. Ibutylast is used for stroke recovery in Japan. It has a marginal benefit in stroke recovery, but it might help prevent brain atrophy, so that's shrinking of the brain. That's being looked at. I mentioned that if you get a stem cell infusion in your veins, they never make it to the brain. But what if I injected them right into the fluid that cushions the brain and spinal cord? That might have a benefit. It's too early to tell, but a phase 2 trial is ongoing right now in New York. And finally, there might be some vaccines that can modulate the immune system in such a way as to not cause MS. There's a company looking into that as well. So to summarize, the goal of MS treatment is to treat active MS, so inflammatory disease, as early as possible. By doing so, we can prevent relapses, we can prevent new MRI lesions, and by doing that, we can prevent short-term disability, and hopefully by doing that, we prevent long-term disability. I know I kind of went rapid fire through a number of different medications, but I don't think we have time to discuss each in detail. These medications all work by different mechanism, and they all have different side effects and have different blood work monitoring. It's very important that this is followed by someone who's experienced in MS care. We do have some criteria for stopping treatment, and there's actually some trials ongoing to confirm these criteria, but MS treatment is not necessarily lifelong. And there's a number of treatments on the horizon, but I wouldn't recommend starting any of them until we have scientific validation. But I think those treatments that might cause repair or recovery of brain tissue, I think that's a very exciting avenue of research right now. I think that's the end of my presentation, so I'm just gonna open it up to any questions that are out there. Thank you for listening.
Thank you, Dr. Poliakov, for that informative presentation. We do realize it's 5 minutes to 1. Are you available for about 10 minutes of questions?
Yeah, that's fine.
Okay. We did have one question come in. Someone was asking you to just repeat the relationship between Tecfidera and the low white blood count.
Yeah, so Tecfidera, when it was initially released, was being touted as having antioxidant properties, and that was its main mechanism by which it helped with MS by something called the NRF2 pathway. I think since then, it's been quite clear that it is an immunosuppressive medication. It generally causes a decrease of lymphocyte counts by about 30%. That's 30% in most people. Now, that is of little consequence unless they get to a level, an absolute level of less than 0.5, and we very rarely see that. With less than, I think it was less than 3% of patients actually dropping to such a low count. However, when we do see the lymphocytes, the white blood cell count drop that low, then we really have to consider switching. In those patients on Tecfidera who have had a low lymphocyte count, less than 0.5, for more than 6 months, they seem to be at increased risk of the brain infection PML, which is the one that we've seen with Tysabri. They seem to be at increased risk of that, but only those patients with generally older patients above 55 with a low lymphocyte count that's been there for more than 6 months. So for the most part, we will switch Tecfidera when the lymphocytes drop to 0.5. That's quite rare. In most patients, when they stop Tecfidera, the lymphocytes will gradually recover back to their normal over time. A very small percentage of those who get low lymphocyte counts, about 5% of those who get low lymphocyte counts, will take a very long time to recover the lymphocytes. It might take years. Again, fortunately, that's rare.
Okay, thank you. We do have another question. They're asking if you could speak to a bit of the so-called Trojan horse research here in Saskatchewan, and how is that different from the intent of Lemtrada?
So I think that's more in the domain of Dr. Levin, who's our MS Clinical Research Chair. I guess I'm not quite sure actually what that refers to in terms of Trojan horse. There had been some research looking at the release of the so-called stress granules, which we see, which was found here in Saskatchewan, which you see as a response to the inflammatory damage of MS. But that has more to do with recovery and healing, as opposed to anything I would consider a Trojan horse. Lemtrada, as I said, as I talked about, is an infusion or induction medication. It works by lowering a certain white blood cell. Again, this white blood cell called the lymphocyte. It actually takes the level down to essentially 0, and it does it really quickly over a period of days. And then the lymphocytes recover. Lymphocytes are made up of 2 types of cells. Some are called B cells, which are lymphocytes made in the bone marrow. Some are called T cells, which are lymphocytes made in the thymus. These both will recover over time. The hope is that as they recover, they are less likely to recognize the brain or spinal cord as a target. That seems to be a relatively effective medication, but there are some side effects of doing that, mainly secondary autoimmune side effects. Like I said, those patients are more likely to develop thyroid autoantibodies and develop thyroid disease. But unfortunately, I can't speak much to the Trojan horse research in Saskatchewan, but I can certainly relay that question to Dr. Levin, our MS Clinical Research Chair.
Okay, great, thank you. We did have another question. If your lymphocytes have dropped to 0.5 while on Tecfidera, is it possible to be able to restart Tecfidera once the lymphocyte count is back to normal?
Yeah, that's a really good question. So that's been looked at in a number of ways, like taking a drug holiday, so stopping the Tecfidera for a little bit and then restarting it. In general, if if Tecfidera causes a significant lymphocyte drop in somebody, it's something about the interaction of that person's lymphocytes and the Tecfidera, and it will almost certainly happen again. So if taking a drug holiday and restarting Tecfidera in the same person will lead to another lymphocyte reduction. So we generally don't recommend retrialing Tecfidera because it's likely the same thing will happen.
Okay, great, thank you. Another question we had is, can a family physician prescribe a DMT or disease-modifying medication?
So in Saskatchewan, family physicians can still prescribe disease-modifying therapy. That's truly kind of exceptional to Saskatchewan. You don't see that in many other places. But we have a very big rural population, so it's hard to get everyone to see a neurologist. Right now, family doctors can only prescribe the first-line therapies. I'm also seeing a shift with most family doctors just referring their patients onto the MS clinic and not being as comfortable prescribing these therapies, especially because there's so many more out there. And some of the first-line therapies are now like Ocrevus, which is an IV infusion medication, and it's considered an immunosuppressive. And I think that most family doctors are not comfortable prescribing medications like that. But technically, yes, they can still prescribe first-line MS therapies in Saskatchewan.
Okay, and actually, this might relate to our next question then. If someone wants to go to the MS clinic in Saskatoon as a patient, can you explain a bit of the process?
Yeah, so we just need a referral. So what the types of patients that we'll see right now include the question as to whether or not somebody has multiple sclerosis. That's usually based on having features that are appropriately suspicious for MS. And that's, I guess, a topic for another day. We'll also see patients who have a established diagnosis of MS for follow-up or for a second opinion or to review their medications and things like this. We just need a referral from a doctor, be it a family doctor or a specialist. And then those referrals get triaged by myself and our nurses. We're happy to see those people. We have some patients who already have a neurologist, and they'll just come see us once and just, like see what the clinic's all about, know the resources that are available there, and then continue to follow up with their neurologist in the community, and that's fine too. But to be seen at the MS clinic, we just need a referral.
Okay, great, thank you. We do have just a few minutes left, so if anyone else has any questions, they can go ahead and type that in. And I don't know, in the meantime, is there anything else that you wanted to add, Dr. Poliakov?
No, I think I kind of maybe just to re-emphasize some of the main points. Again, that the treatment of MS is mainly looking at treating active disease. It's unfortunate that we can't do much for progressive disease, and it's unfortunate we can't do much for advanced disease, but hopefully there'll be some treatment avenues there in the future. But what we have now are what I think are effective medications for early MS, but they have risks associated with them. And there's this saying that no medication with an effect is free of side effects. So there are some risks to these medications, but they're appropriate in early MS. But we just have to use them appropriately in all other types. So we have to be realistic about what these medications can and can't do. But if somebody has active MS, then there's a good chance they'll benefit from one of these medications, and it's just important to review with a neurologist.
Okay, great, thanks. We have one more question. What are your thoughts on CBD for symptom treatment?
So CBD will hopefully be studied more, and we're actually even looking into, there's a kind of Canada-wide push right now to study the effects of CBD on various symptoms in various disease states, MS being a topic of particular interest. The evidence we have right now is that the certain symptoms in MS, specifically muscle tightness, pain, bladder spasms, can all be helped by CBD. The pain itself is actually more likely helped by THC, which is the more psychoactive component of marijuana, where the rest are helped more by CBD, which is the much less psychoactive component of marijuana. I think in those areas there is some benefit. In general, I would recommend trying a more established medication first for pain like gabapentin or amitriptyline. But if that fails, I think it's quite reasonable to try a cannabis formulation. Cannabis has side effects though. So one, probably the most important one, especially in advanced MS, is cannabis worsens balance and worsens walking. So there's an increased fall risk. We see that especially in our elderly patients. In patients who have a family history of psychosis, cannabis can actually trigger psychosis. We know for sure cannabis, especially THC, worsens short-term memory and worsens reaction speed in the short term. This is why you simply cannot drive when using cannabis. It cuts reaction speed in half. Luckily, that's reversible. And then finally, for some people, cannabis can actually make anxiety worse and rarely can make nausea worse. So there are side effects. So I treat it like any other medication. Start low, go slow. Start with the lowest dose, gradually increase it, and then to see if it's effective. I've had some patients who really find that their muscle tightness, that is spasticity, or their pain is improved with cannabis. I've also had many patients, I'd probably say the majority, just have not noticed much of a benefit. When we look at places where marijuana has been legal for a long time, like Amsterdam, there's generally not too much use of marijuana for MS.
Okay, great. Thank you so much. So it is the end of our time. If your questions were not answered today or you do have additional questions, you can discuss this with your family physician or neurologist. You can also reach out, as Dr. Poliakov said, to the MS nurse at the MS Clinic in Saskatoon, and you can call the number 306-655 7742. You can also call the MS Knowledge Network and you can speak with a navigator. The phone number there is 1-844-859-6789. So once again, thank you so much, Dr. Poliakov, and thank you to everyone for participating in today's webinar. It has been recorded, and as a participant, you will receive an email with the link, so you may rewatch or share with your network of family and friends.